Hello, I'm Robert Giugliano, a cardiologist at the Brigham and Women's Hospital in Boston, Massachusetts. I'm here with my colleague, Dr. Christopher P, also from the Brigham and Women's Hospital, and we've just heard the results of the Improve It study, one of the landmark trials being presented at the American Heart Association's 2014 sessions here in Chicago. We're happy to be here today and share with you some further insight on this important trial. Of course, Improve It was asking a few important questions and was started back in 2005 regarding lipid management in patients with acute coronary syndrome. One of the questions being, how does this non-statin therapy, ezetimibe, which blocks cholesterol absorption, work in patients with acute coronary syndromes? Does it reduce future cardiovascular events? And a second related question is, we looked at patients with, I'd say, moderate levels of cholesterol, LDL 50 to 125, and we're asking the question, is even lower even better? Since we anticipated we'd have cholesterols on average, LDLs on average around 50 or so in the ezetimibe arm, whereas on the simvastatin alone arm, we were looking at cholesterols around, LDL cholesterols around 70. Of course, along the way, in any long journey, you can run into unexpected events, and there were also some external events that raised questions about the safety of ezetimibe, so that was a third question that was added during the duration of this trial. But I'm glad that I have my colleague, Dr. Christopher P here, who can tell you straight from the horse's mouth what the trial showed. So Chris, let me hand it over to you.
Well, Bob, we and probably about 3,000 other people have been working on this for a long time, and we randomized 18,144 patients in the 10 days post-acute coronary syndrome. Everyone was treated with a statin, starting with Simva 40, up titrated to 80, and then half got ezetimibe added. And our primary endpoint was significantly reduced when adding ezetimibe. It was a 6.4% reduction, a p-value of 0.016. All three of our major secondary endpoints were reduced, and when looking at the individual components, we found, as expected, no difference in mortality, but a reduction in MI and stroke as the major things that were reduced with this additional LDL lowering with ezetimibe. The other thing that's been really neat to see is that the safety profiles found no difference versus the statin alone group, and so it really confirmed the safety that we've known. And so I think encouraging that we have gotten answers to yes on the big question of whether a non-statin drug could have benefit. We also did achieve lower levels, and so the question is, could we be pushing even lower still? And nice to have a drug with a good safety profile to do that. I guess that one of the questions is, what does this mean for the field? Do we need to change the guidelines? And what about all the new drugs that are in development, like PCSK9?
Right. No, I think those are important questions, and I imagine many of you who are treating patients with hyperlipidemia and acute coronary syndrome are thinking about, well, what am I going to do in practice? So we look forward to see how the guidelines adapt to these new data. I guess personally, when I think about it, first of all, patients who are on ezetimibe, I think I'll continue. And then those who aren't able to achieve the LDL that I want, particularly if they're early post-ACS, I feel very comfortable adding ezetimibe. And I guess the tougher question, and maybe I'll toss this one back to you, is what do you do for the patient who de novo comes in with an acute coronary syndrome? Do you think high-intensity statin alone, with and without ezetimibe?
Well, it's a good question. I think we as a group have to digest this. That's our direct evidence that there would be added benefit. And we might want to adjust to the baseline LDL, and so we'll certainly be seeing. And then I think encouraging for the field that other agents that have like a 50% further reduction in LDL, that might, but we'll have to see, translate into even greater benefits. And so,
I agree. I think that's the thing as a scientist that made me most excited about this trial, right? I mean, it was really the first time we've seen a non-statin agent added to potent statin background therapy reduce cardiovascular events. And of course, I don't want to get ahead of myself and overgeneralize, but I think for the PCSK9 inhibitors, this is a strong positive signal, and so there's great hope.
Yeah. Well, thank you all very much for joining.